Hello guys, welcome to our lecture series. Today's video focuses on the cutaneous manifestation of sarcoidosis. But before we begin, let's briefly go over what sarcoidosis is. Alright folks, let's dive into sarcoidosis. It's a complex disorder that affects multiple systems in the body. Picture this, non-caseating granulomas making themselves at home in various organs, leading to a range of symptoms and complications. Well, who is more at risk? It tends to hit young and middle-aged adults, with women more frequently affected than men. And here's an eye-opener. The black Americans face about 3 times the lifetime risk compared to their white counterpart, often experience more severe and acute cases. Sarcoidosis risk varies by age, sex, race, and ethnic background. The disease is more common in African American women. It is estimated that sarcoidosis prevalence is 60 per 100,000 individuals in United States. That's quite a lot. So let's shed some light on a few key symptoms you should keep in mind. Malaise, fever, cough, and dyspnea. While these may seem like everyday occurrence, they can sometimes signify more than meets the eye. So now let's talk about the skin involvement. Well, it's a topic we'll cover more in more details later on. But for now, just know that it's an important aspect to consider. Moving on, there are other signs you should be aware of, from iritis to peripheral neuropathy, from arthritis to cardiomyopathy. These manifestations can provide valuable insight into various health issues. So you have to be a good historian. You have to ask for symptoms, like you have to ask for arthritis, you have to look for the murmurs, you have to look for the pedal edema, you have to auscultate chest, you have to look for the visual symptoms. So what's particularly interesting is that not everyone experiences these symptoms in the same way. Some individuals may not show any symptoms at all and are only diagnosed through abnormal chest x-rays, which are done for some other purposes. It's a reminder that health conditions can present themselves in unexpected ways. So, as you navigate through your studies and campus life, keep these symptoms and manifestations in mind. Stay curious, stay focused, stay informed, and remember that knowledge is your greatest asset. So, welcome aboard. So, let's discuss the laboratory abnormalities associated with sarcoidosis. First up, we have leukopenia, which refers to low white blood cell count. Is an important indicator that your immune system might not be functioning at its best. Next, we have an elevated ESR, which stands for erythrocyte sedimentation rate. This measures the inflammation in your body. If it is high, it could mean that there is some sort of inflammatory process going on. Then there is hypercalcemia, which is when you have too much calcium in your blood, and that is because of the increased alpha hydroxylase activity of macrophages in the caseating granulomas. Next is hypercalciuria, which is similar but focuses on excess calcium in your urine. It's another clue that something might be off with your calcium metabolism. Lastly, we have an elevated ACE levels. ACE, or angiotensin converting enzyme, is involved in regulating blood pressure and fluid balance. If it is elevated, it could indicate certain medical conditions, particularly those affecting the lungs, just like sarcoidosis. So now let's talk about some physiological tests you might encounter. Airflow obstruction or restriction on PFTs refer to pulmonary function test. In case of sarcoidosis, there is fibrosis going on with the passage of time. So you will see a restrictive pattern. In case of ECG or the electrocardiogram, you can see certain type of blocks, AV blocks, because sarcoidosis is associated with conduction blocks, and that is because of fibrosis of the conduction pathways. So, on the basis of lung involvement, there are basically 5 stages of a disease: stage 0, stage 1, stage 2, stage 3, stage 4, and there is no stage 5 because we already have a stage 0. So, in stage 0, there is normal chest x-ray, but patient is having a disease. He or she has come to you with signs and symptoms, but the findings are normal, and the frequency of presentation is 5 to 15%. In stage 1 disease, there is nodal or mediastinal enlargement, but there is no parenchymal activity, and the frequency of presentation is 25 to 65%, and most of the patients present at this stage. In stage 2 disease, there is nodal enlargement as well as there is parenchymal disease as well. And stage 3 is only about parenchymal disease. In case of stage 4, which is the end stage lung disease, and there is fibrosis of the lung parenchyma. At this point, the treatment options, which are mostly steroids, will not work anymore. So this is about the stages of sarcoidosis. So these are some radiographic findings. So in the first stage, you can see there is hilar limb retinopathy. And the second stage, you can see there is hilar limb retinopathy as well as the parenchymal involvement. In the third stage, you can see there is only parenchymal disease. In the fourth stage, you can see a lot of fibrosis going on in both lungs. So since stage 0 comes with without any radiographic findings, so you'll skip that. Diagnosis. Unfortunately, we do not have any specific test for sarcoidosis. The diagnosis depends on 3 elements. Number 1, compatible clinical and radiographic manifestation. Number 2, exclusion of other diseases that may present similarly. Number 3, histopathologic demonstration of non-necrotizing granulomas. So, in case of biopsy, we prefer to use the least invasive methods that are likely to achieve a diagnostic sample. For example, in extrapulmonary manifestation of a disease, the skin lesion or a subcutaneous nodule is preferred, while in case of intrathoracic presentation, bronchoscopy is preferred over surgery. So, histological findings. A non-caseating granuloma of sarcoidosis consists of epithelioid histiocytes, giant cells, and mature macrophages. You can see them on your screen. In this slide, you can see this ring of cells which is labeled as MGC. This is actually a giant cell. And you can clearly see a star-shaped structure which is an intracytoplasmic inclusion. It is labeled as AS. And this is called asteroid bodies, like star-shaped. So there are also other cytoplasmic inclusions such as Schumann bodies and crystalline inclusions. So what are the treatment options? Oral corticosteroids such as prednisone or prednisolone at a dose like 0.5 to 1.0 mg per kg per day are used for various indications. Long-term therapy is usually required, and you don't want long-term therapy with steroids because they can give you a lot of side effects, such as they can swell your face, they can cause abdominal stria, they can weaken your skin, they can cause easy bruising, they can weaken your muscles, and even psychiatric symptoms. So that's why we need to keep you off the steroids. And for that purpose, we use immunosuppressive medications such as azathioprine, mycophenolate mofetil, or methotrexate. But we will not discuss these treatment options in this video because we are already making a separate video for treatment. For now, you only have to remember that the oral corticosteroids are the mainstay of treatment for sarcoidosis. The treatment options are corticosteroids, which are first line. The second line agents include methotrexate, azathioprine, leflunomide, and mycophenolate mofetil. The third line agents are the TNF antagonists, infliximab and adalimumab. As I mentioned earlier, steroids can give you a lot of side effects, and you don't want these side effects. So the second line agents specifically methotrexate, azathioprine, leflunomide, are used to keep the patient off steroids. They are the savior in that case. So we are not going to discuss treatment options in details because we are already making a separate video on this topic. Prognosis. So in terms of so now let's talk about the cutaneous manifestations. The cutaneous manifestation of sarcoidosis can be divided into two types: the specific lesions and the non-specific lesions. So the specific lesions are the lesions which contain non-caseating granulomas, which represent the classic histopathologic finding of a disease, while the non-specific lesions are all the other diseases that are associated with sarcoidosis but do not demonstrate the non-caseating granulomas. So it's basically the non-caseating granulomas which differentiate specific from the non-specific lesion. So on your screen, you can see there are 6 lesions which are called the specific lesions of sarcoidosis, but there are many more. So papular sarcoidosis, plaque sarcoidosis, nodular sarcoidosis, subcutaneous sarcoidosis, lupus pernio, hypopigmented sarcoidosis, etc. So these are some of the lesions we will cover in this talk. So while the non-specific lesions include erythema nodosum, erythema multiforme, Sweet syndrome, calcinosis cutis, prurigo, and neoplasia. So these are non-specific lesions. They do not demonstrate the classic histological presentation of a disease, that is the non-caseating granulomas. So papular sarcoidosis. Papular sarcoidosis is a type of specific lesion. In papular sarcoidosis, there are numerous non-scaly 1 to 10 mm papules. These lesions are skin colored, they are yellow to brown, they can be red to brown, violaceous or hypopigmented, and sometimes they demonstrate a single central depression. So although these papules can develop in chronic disease, they can also manifest in acute sarcoidosis. So papular sarcoidosis most frequently occurs on the face, with a predilection to the eyelids and the nasolabial folds. The plaque sarcoidosis. So plaque sarcoidosis often presents with oval or annular, indurated, and discrete plaques. There are skin-colored, erythematous, or brown. So occasionally scales are also present, and that's why they are confused with plaques of psoriasis. But the frequent site of involvements are the shoulder, arms, back, and buttocks, as you can see on the image. So atrophic and ulcerative sarcoidosis. So atrophic sarcoidosis is a form of plaque sarcoidosis that presents with depressed rather than elevated plaques. I repeat, depressed rather than elevated. And this occurs in minority of patients with sarcoidosis. And in one retrospective series, ulcerative atrophic sarcoidosis was detected in 7 out of 147 cases of cutaneous sarcoidosis, that is 5%. So all patients with ulcerative sarcoidosis, ulcerative atrophic lesions present with other mucocutaneous membranous manifestation of sarcoidosis. And the majority of these patients had internal disease. So lesions of atrophic sarcoidosis may share features with the lesions of with morphia. That's the skin condition that affects your nose. So nodular sarcoidosis. Nodular sarcoidosis primarily involves the subcutaneous tissues. This disorder is more common in females and it has predilection to middle-aged adults. And sometimes it is associated with autoimmune diseases. Subcutaneous sarcoidosis presents as erythematous, skin-colored, violaceous, or hyperpigmented nodules. And on the forearm, sometimes these lesions coalesce to form linear distribution, and sometimes they form bands. So, guys, whenever you talk about sarcoidosis, you talk about lupus pernio as well. Lupus pernio is a distinct form of cutaneous sarcoidosis. It disproportionately affects black person and females. And the presence of lupus pernio appears to be associated with an increased risk of extracutaneous manifestation of sarcoidosis. That's why thorough examination of the patient with lupus pernio is very important. So in one case series, there were 35 patients, and in those patients, the intrathoracic disease, lymphadenopathy or pulmonary abnormalities, upper respiratory tract disease, reticuloendothelial system involvement, and ocular lesions were present in 74, 54, 54 and 37%. That's quite a lot. So that's why whenever you see a patient with lupus pernio, always dig for the internal manifestation of a disease as well. So the lesions of lupus pernio are characterized by violaceous or erythematous, indurated infiltrative plaques that are primarily distributed on the central face, usually the alar rim, the nasal tip, and the cheeks. Other frequent sites of involvement include the ear and the lips, and less commonly, the lesions may also affect the dorsal hands, fingers, or toes. And of note, very important, not all the lesions on the nose are lupus pernio. So that's why you have to keep your differentials wide. So in these images, you can see the lesions are predominantly distributed on the nose. They are thick, indurated, and erythematous. So these are typical for lupus pernio. But again, not all the lesions on the nose are lupus pernio. So always keep your differentials wide. Unfortunately, lupus pernio is less responsive to treatment, and the lesions sometimes heal with scarring. And without treatment, the lesions progressively infiltrates and indurates, eventually result in disfigurement of the face. So you will prefer scar over disfigurement. That's why treatment is important. Hypopigmented sarcoidosis. So this entity is an uncommon clinical manifestation of sarcoidosis that is most prominent in individuals with highly pigmented skin. You can you can easily appreciate the hypopigmented lesions in a dark individuals than an individual with a fair skin. So the lesions are hypopigmented, well demarcated, round to oval macules, patches or barely raised plaques. And sometimes they have a central normal colored skin, and that's why it gives an appearance of an white egg. So now let's discuss the non-specific manifestation of sarcoidosis. So you have to recall the previous slide. So in this slide, you can see we have different regions like erythema nodosum, erythema multiforme, sweet syndrome, calcinosis cutis, prurigo, and nail scrubbing. So all these are non-specific regions. And they are non-specific because they do not demonstrate non-Casherian granulomas of sarcoidosis, which is very typical for the disease. So in this slide, we will talk about erythema nodosum. Erythema nodosum develops in about 25% of the patients with sarcoidosis and is clinically and histologically identical to erythema nodosum that occurs secondary to other causes. And, and you can recall numerous causes of erythema nodosum. We have lots of mnemonic on the internet for erythema nodosum. So the lesions of erythema nodosum are tender. They are subcutaneous nodules or plaques, predominantly located on the anterior tubular areas. Arthritis, lower extremity edema, and low-grade fever are the most common systemic symptoms associated with erythema nodosum. One of the very important uh, thing you have to remember about erythema nodosum is that it is very good prognosis. Whenever a disease is associated with erythema nodosum, it is a good prognosis. So guys, coming up next, treatment options for sarcoidosis. We will cover treatment options in detail in our next video. Stay tuned, stay focused, and remember that knowledge is your greatest asset. You're welcome. If you enjoyed the content, subscribing and hitting the bell icon ensures you won't miss